practitioners with all the latest research and clinical updates in ACVD and lipidology, enabling HCPs to optimize patient care in clinical practice. Our distinguished speaker for today's webinar is Dr. Samer Ellahham, who is a staff physician in the Heart and Vascular Institute at Cleveland Clinic, Abu Dhabi. In today's presentation, Dr. Ellahham will discuss the role of lipoprotein A in cardiovascular disease risk and possible ways to manage and treat LPA levels in patients. We request you to send your questions through the chat box and respond to the polls that will be presented to you during this webinar. At the end of the talk, we'll present your questions to our speaker.
Hello, and welcome to our discussion today on lipoprotein and cardiovascular disease. I call it a discussion because I'm hoping that at the end of my presentation, we'll have a good time to have a Q&A. The topic is very important, I think, and very timely. Some of us are aware of the lipoprotein a. Some of us may not. Some of us order lipoprotein a routinely, and some of us may never have heard of it or even ordered it in the past. I was in a conference and I was discussing lipid management and dyslipidemia, and I was quite surprised that very few people knew about Lp(a) and even less order Lp(a) on their patients. My name is Samer Ellahham. I'm a clinical professor and a cardiologist at Cleveland Clinic Abu Dhabi. My other interests are in improvement and quality. So this is really the outline. I strongly believe in tell them what you're going to say, then say it, then summarize it. I'll briefly talk about cardiovascular disease and lipid disorders. We will try to dissect as much as we can with the limited time that we have lipoprotein A, or what we should call it lipoprotein a. How prevalent is it? What's the structure? What is the distribution? How can we measure it? And this topic of measurement, quite honestly, need a whole session, but I'll be as brief as I can. Then I'll move to the association of elevated Lp(a) with various diseases, especially atherosclerotic cardiovascular disease. And then the tough topic of the management of elevated Lp(a), then a summary. And my summary will be quite extensive, 3 slides. I think there is so much for us to know and remember about Lp(a), and I'm truly excited that we're discussing this very important topic. Cardiovascular disease is common, and you've heard it, and I've heard it locally, regionally, and globally. I am currently in Abu Dhabi, in the United Arab Emirates, as I said, at Cleveland Clinic Abu Dhabi. Whether my colleagues and my delegates are in the region or globally, we all know that cardiovascular illness is not only a global, literally disaster, but we're being very reactive in treating this disease. We're very excited about doing angioplasty and percutaneous intervention, and it's important. Coronary artery bypass surgery, it's important, but it's really like a firefighter, isn't it? By the time we try to do something, it's already quite late. The disease already progressed, and we are trying to modify the disease, but the fire and the burn is already there. And as you know, not only we have so many patients dying, as I'm showing this slide, with cardiovascular disease, but more importantly, high cholesterol, elevated cholesterol, so-called dyslipidemia or hyperlipidemia is truly #1 or even the top, when we add it to hypertension and diabetes, and should never be belittled. Left untreated, which happens so many times, this is something that is really leading to progression and many times to death, even before arriving to the hospital. Now, we talk about lipid disorders and we talk about congenital lipid disorders. So, for example, something that you and I talk about quite frequently, dear colleagues and fellow listeners, we talk about heterozygote hyperlipidemia and we talk about homozygote hyperlipidemia. Now, homozygote, we know it may be 1 in 300 million or so, but the heterozygote one, people talk about it all the time, especially my fellow cardiology colleagues. We're talking about 1 in 250. Would you believe that an elevated Lp(a) is as common as 20% of the population? Yes, 20%, one-fifth of the patients can or may have elevated LP little a. It's really something that runs in family, and I'll talk about it in a second. And it is something that is rarely checked. As I told you, nobody even check the LP little a, not even once in a lifetime. It leads to significant vascular disease, and it is a genetic variant, and there are some variants more aggressive than others. Not only that, but this entity, this concern, this biomarker, this LP little a can also affect the aortic valve, leading to aortic valve stenosis. So you could look at the numbers, and whether you go from the left to the right or right to the left, this entity is very common. The elevation in the lipid of the LP little a is quite common. And we're talking about something that's markedly underestimated. This is a very important paper that I highly recommend that you would review. I took from it the estimate of the prevalence of the elevation in LP little a. Our colleague in California here quoted the numbers as greater than 50 milligram per deciliter, which is typically an acceptable number for elevated LP little a, or greater than 125 nanomole per liter. And another topic is the issue of the units. One-fifth of the population could be close to 1.4 billion, if not 1.5 billion worldwide. Imagine that many of us do not even test this, don't even know our own LP little a, let alone family ones and patients. Why should we care about it? First, let's know more about it, and I'll try to be as brief as I can. This is a very important slide, I think, that I want you to memorize as a concept, not as the detail. And as you can see here, this looks like it has an LDL component to it, LP, and has an A component to it, LP little a. And as you can see, there's a disulfide connection here. And the disulfide connection links us to something called kringles. We say that they simulate Danish pastries. And the idea behind this is not only do we have the ApoB100, which we find in LDL particles, but the second component is the Apo little a. And you could see that there are several kringles here, in addition to the LDL, in addition to the apoprotein little a. There are many kringles, and depending on the size of the kringles, the frequency of the kringles, and many other congenital this structure will give us even more interesting pathophysiological concerns. To dig a little bit, and I have limited time, so I'll be brief, LP little a levels are primarily regulated by the ApoA gene, which I just showed you, the ApoA or Apo little a, polymorphism, namely the copy of the number of the kringle domain, especially the fourth kringle domain. If there's anything you remember about the slide, just remember the fourth one. And it may be counterintuitive, but individuals with low number of repeats that have small ApoA isoform have higher plasma LP little a concentration. One more time. The patient that have a low number of repeats, have a small ApoA, have higher LP little a. And it's very interesting that there are data on some forms of LP little a that are even more associated not only with vascular disease, but also with aortic valve stenosis, which I will discuss later. This slide is a very interesting slide that shows us the three components of the concern about LP little a and why it is pathogenic. It has a pro-inflammatory component, mostly focusing on oxidized phospholipids. I always tell my colleagues that if you have a patient that has COVID-19, make sure you know what is their LP little a, because the so-called cytokine storm may be, and there are data on this, but for the interest of time, I've removed the slide, that those patients may be more likely to have a storm, may be more likely to have a remarkable cytokine storm. On the other side, it's the usual LDL thing, which is the pro-atherogenic. In these cases, somewhat similar but more aggressive than your typical LDL. On the right side is the prothrombotic. This is where it gets even more interesting because there is a similarity between plasmin and this entity, the LP little a biomarker, I call it. There is decrease in plasminogen activation, decrease in fibrin degradation, and increase in clotting, including an increase in platelet responsiveness. So this is a triad or a trio of a concern, and yet Lp(a) is rarely, if ever, checked on patients and even physicians and family members. The proposed pathological mechanism from the Wilson paper that I show here that looks at atherosclerotic cardiovascular disease and aortic stenosis is even more interesting. Looking at Lp(a) and looking at the thrombotic component and the atherosclerosis, you could see that this would lead to plaque rupture, stroke, vascular disease, and very interestingly, in some subgroups and subcomponents, a remarkable inflammation and aortic valve stenosis. Something interesting. How many times do we even know in our patient, and I'm sure you've seen this, some patient progress very quickly with aortic valve stenosis. We do the echo after 6 months or 1 year, and we are surprised how quickly they go. And then some patients really go a long while, and there is minimal change, if any. Could Lp(a) be at least one of the reasons for such a progression? Something interesting to keep in mind. Serum Lp(a) levels are genetically determined. This slide is very simple but very practical, and I really like it. Lp(a) is inherited as autosomal codominant. So not only is autosomal dominant, it's coming from the father and the mother. And you could have in the same patient different aspects of this Lp(a). It's on chromosome 6. We can inherit only one Lp(a) allele from one of the parents, or we can even have one allele from a parent with some, a description versus the other one with a totally different description and different nature. And again, talking about the 2KIV that I spoke about, or the 41, the Kringles, which I mentioned to you, the one that look like Danish pastries. Small Lp(a) are easier for the liver to produce, so a person with fewer of these Kringles repeats will have a higher Lp(a). And it may initially be counterintuitive, but if you think about it, it makes some sense. This slide, I could literally spend an hour discussing. I'll be as brief as I can, the impact of ethnicity and genetic component and the environment and medical conditions. Very briefly, this is from a very interesting paper published in 2016, looking at the apogene, the isoform, and the plasma Lp(a). There is a genetic component looking at the apo(a) size polymorphism. I already spoke about it, and the SNPs. There are also an interesting racial and ethnic variation. So African Americans will be different than white. Blacks could be different than whites, Indo-Asian, Middle Eastern, where I'm currently practicing now, and then many others. Very interesting data that I'll try to briefly share. Age is important. Gender is important. Diet, while it may be important, we are unable to discern a significant impact of diet on improving or lowering the Lp(a). Exercise the same. Inflammation, interestingly enough, this Lp(a) may change with infection, with inflammation, even with acute stress. So if you have a patient coming in with an acute myocardial infarction, we don't recommend getting the Lp(a) the first 24 or 48 hours because it may be falsely increased. If patients have infection or inflammation, this biomarker may be an acute phase reactant in a way, which is interesting. So people tell you, test it once in a lifetime, but when you are stable in a stable condition. Menopause, interestingly enough, estrogen would lower our Lp(a). In patient with menopause, it can go up and increase. So although people say do it once in a lifetime at least, it's interesting to keep in mind that there are some changes. And again, pregnancy would affect it. Medical conditions, patients with kidney disease and liver disease are likely to have higher numbers. Some endocrine immune conditions, especially if you have inflammation, may affect it. And diabetic patients, as if we need more issues with diabetes, may have higher levels of Lp(a). The Copenhagen General Population Study is very well known to all of us, and some of the groups that led these studies are the ones that really looked at Lp(a) and even coined some of these terms. Notice that in the slide to the left, the plasma level of Lp(a) are similar really in general between men and women, something very interesting. If you look at the famous Dallas Heart study and looking at Lp(a) with the levels, you could see that there are some interesting findings that show up that are worthy of our attention, both as clinicians and as researchers, and hopefully all of us are both clinicians and researchers. So you could see that the Lp(a) levels were higher in our colleagues, Blacks and Hispanics, female compared to their male counterparts. However, the levels in the female versus male were very similar. I mean, these are not huge differences, but things worthwhile and very important for research. And I think all of us need to be involved in research, especially in the field of Lp(a) in one way or another. Again, there is variation. If you look at Asians, for example, where I'm typically now, I'm in Asia, you could see the numbers. I will not read the slide for the interest of time. Caucasians can vary significantly. African descent can vary, and the numbers could vary. Not only that, but if you look at the Framingham study and the AIM High study, there are some variations related to the ethnicity and related to the background of the patient. So the cutoff may change, and also the technique for measuring Lp(a) may vary, and also the unit, milligram versus nanomoles. Measurement, that by itself is worthy of a whole lab discussion that would take 3 to 5 days. But for the interest of time, as a clinician, as a researcher, and as a quality person, I will tell you that we need to use appropriate calibrators, standardize the protocol, make sure we have appropriate traceability, and reporting units is a whole challenge by itself. There are some standardized, we call it CAP, College of American Pathology, standardized approved ones, and we also have some standardized ones from chemistry colleagues. Just please remember that when we report the unit, I think eventually we'll all report it not in milligram, but rather in nanomoles per liter. And that's really something important to keep in mind. Can you make this a little bit more clear? The preferred assays for report, as I said, will be nanomole per liter rather than milligram per deciliter, where many of our colleagues in the United States are more commonly using. Now, one way to convert is not really perfect. You may remember it just for the interest of practicality is the Lp(a) in milligram per deciliter. If you really divide it or convert it using 2.4 or 2.5, you may be able to have a number that makes a little bit more sense. So for example, if you have 125, divided by 2.4 or 2.5, you get the 50 milligram. And that's one way to convert it. Easier number to remember that I've seen being mentioned by WHO, by European societies and American societies and Asian societies are the greater than 50 milligram per deciliter is probably elevated, and greater than 125 nanomole per liter is probably elevated. And I hope this makes sense. It's really a fun topic, and the recommendations may help us understand it better till we have more data and more interventions. For the measurement of Lp(a), and I pulled for you this from different guidelines and different societies, it is recommended to have an immunochemical assay that's calibrated against what we call a WHO reference. And if you are asking labs and quality and reference are not something that you may be particularly interested in, just remember WHO secondary reference lab, and that usually tells you that this lab is quite good. When using values in risk assessment, we don't recommend to use what I told you, 2.4, 2.5 in the guidelines, but I just thought to mention it to you because I found it in some articles, and if we're desperate, we can go from nanomole to milligrams. When Lp(a) values are being used, rough numbers to remember, 50 milligram per deciliter or greater than 100 to 120 may portray a high risk, and this is a 2A indication from the guidelines. Now, what does the European Society of Cardiology recommend? So something very interesting. Number one, they recommend to have it at least once in a lifetime, and we recommend to do it for an adult. So maybe after puberty, or even sooner, according to some pediatric guidelines that are beyond the scope of our discussion today. The second thing is they define very high inherited LP little a as greater than 180 milligram per deciliter, or greater than 430 nanomole per liter. And these would have what they call a very high lifetime risk of vascular disease. And those are similar to those with heterozygous familial hypercholesterolemia. So that is message number one from the European Society. The American Heart Association and the American College of Cardiology guidelines did use, did not mention specifically the screening, although I would think that common sense tells us, and it's okay sometimes to use common sense, that all societies would recommend that an LP-A will be tested at least once. The LP-A that they use as a cutoff is the 50 and 125, which I mentioned to you with the different units, and that those will be called risk-enhancing factors in patients 40 to 75 years old without diabetes, but with a 10-year risk of 7.5 to 19.9%, would favor initiation of therapy. Because, one of you would say, and I would say, why would I care about LP-A? You're going to tell us at the end that exercise may not make a difference in LP-A, but makes a difference in many other things. The diet is very limited data, flaxseed mentioned here and there, and, turmeric and, ginkgo biloba and a few other things, with limited outcome data showing that if you lower it, the outcome will be different. You're going to tell us that the statin may not work and even raise it a little bit. Why would we care? In this case, the reason, and I will start quickly to address these things so we are still aligned. In this case, what we all recommend and the experts recommend and the guidelines is to even be more aggressive, more strict about lowering the LDL, having a blood pressure less than 130/80 in the appropriate groups, having hemoglobin A1C in the normal and low normal range, losing weight, exercising at least for 30 minutes, daily, etc., etc. So this may be almost like a CT calcium score or whatever you use for risk indicator may push or pull the patient in the direction of you need to be more strict, you need to be more compliant, etc. The National Lipid Association LP-A testing is reasonable to refine our vascular risk, and they talk about at least 3 groups where it is highly recommended. First-degree relatives of patients who have premature vascular disease, and we're talking about less than 55 in men, less than 65 in women, personal history of premature vascular disease, and primary severe hyperlipidemia, where the patient is coming with very high LDLs in the 190 range, or suspected of having familial one, because it will add up even more concern. An interesting thing that I've added here is the AHA scientific statement to verify the LP-A and be aware whether the patient has systematic inflammation. I told you it may be an acute phase reactant in many cases. This slide is a little bit complicated, but the message from this slide is, in addition to the primary lipids panel as a non-fasting one, an LP-A need to be ordered. Does it matter if you are fasting or not? Absolutely not. It makes no difference. It does make a difference as an acute phase reactant if the person is in acute, a phase of any disease, especially inflammation, infection. This comes from the UK, and I find it to be very simple, very easy to understand, very practical. 5 fingers in one hand and 5 things to remember. LP-A testing can help in high-risk patients. 1, patient with a personal family history of premature vascular disease, especially less than 60 years of age, consider it or recommend it. Number 2, first-degree relative of patients who have LP-A levels that are elevated. I know what you're going to say. At one time, we said 100, then 150 or 125, and now 200, but this is from the guideline. And it's something really worth considering. 3, patient with familial hypercholesterolemia or other genetic forms of dyslipidemia. 4, patients with calcific aortic valve stenosis, all the echoes and The MRIs and all what we do, a blood test should not be very difficult to do in these cases. Or, and that's number 5, a borderline increase, but less than 15% of the 10-year risk for cardiovascular events. And then consider a specialized lipid clinic for these patients. So I hope you're still with me and you are as excited about a topic that I think is not always brought to our attention. And if it is brought to our attention, we're not really doing much about it. And I think help is on the way, and we're going to be able to know a lot more about Lp(a), whether it really affects not only the outcome of the patients, because we know it does, and it affects also the outcome of vascular disease and aortic valve disease, among others. But very importantly, if we intervene and specifically lower Lp(a), is that going to give us different outcome data in the appropriate or a good direction that we are hoping for? So this is now looking and digging in the next few minutes, and I hope you are still with me and as excited as I am about the topic. This is looking at Lp(a) and whether it really correlates in a statistical fashion using different methods and different cutoff points with atherosclerotic cardiovascular disease. And as you can see, it's a linear rise. So it's obviously very clear and very strong one. Now, there's modest increase in atherosclerotic vascular disease for Lp(a) across racial groups too. So really a high lipoprotein concentration, greater than 150 nanomole per liter, was, for example, here present in almost 12% of those without and 20% of those with pre-existing atherosclerotic vascular disease. So it seems to have great, power here to show us the relationship, and it seems to really be there with very large number of patients and different ethnic groups. Fourier trial has been discussed for the PCSK9 inhibitor. I think all of you know about the Fourier. I'm going to take the angle of the highest quartile, which is 4, of the patient that started with an Lp(a) that is quite elevated. And you would see that consistently, although this PCSK9 inhibitor and the other one do lower modestly to a certain extent Lp(a), but there was consistently an increase in cardiovascular need for interventions, death, myocardial infarction, and cardiovascular disease. So very interesting. And again, in the Fourier, when you look at the greatest coronary risk in the top decile, which are the ones that are 230 nanomole per liter and above, again, the highest risk when you look at the subgroup analysis and the risk in these patients. What is the relationship with familial hypercholesterolemia? Again, as if it's not enough to have one problem. What about having those 2 problems and sharing the concern? So there is an increase in the prevalence of Lp(a) in patients with familial hypercholesterolemia, and that was specifically looked at as an increase in a single risk allele, and we call it BCFH, and the familial cholesterol hyperlipidemia. So since Lp(a) contains LDL, familial hyperlipidemia or hypercholesterolemia individuals with a risk of this allele can even have more risk, and they need even more attention. And this was a relatively recent paper published in JACC. So again, just remember that the patient with familial hypercholesterolemia can have, again, an elevated Lp(a), and both of them will even increase the risk even more. Now, this is an interesting concept here from a gentleman whose name is always associated with this entity, elevated Lp(a), Dr. Tsimakas. He's had one of the best publications you can imagine, has papers in JACC in 2017 and 2018, can't even stop breathing, with great illustration. But what I mentioned to you, I bring up again. Inflammatory mediators, IL-6, interleukin-6, is increased in the cytokine storm that can develop during COVID-19 infection. We're not done with it. And I'm sure you know about some cases rising in the Far East. Interleukin-6 can also increase the levels of Lp(a), raising the possibility that these patients will have cardiovascular complication, poorer prognosis, and what I told you, which is the cytokine storm that I'm sure you've heard about. So I think you could see this triangle that I mentioned in the past. Now the difficult topic, management of high Lp(a). So I've shown you so far is this is something that is under-recognized, rarely checked even on physicians and caregivers, nurses, pharmacists, etc., let alone the patients. It's a global thing. People really don't know about it very well. There are some debates, although I think we have a reasonable way to cut off, the low, the normal from the elevated and markedly elevated. It correlates interestingly, and I don't want to say nicely, but in a way it's nicely, with cardiovascular disease and atherosclerotic cardiovascular disease. We can see that the prognosis from a risk standpoint is worse when Lp(a) is elevated, but we don't have a target that addresses Lp(a) selectively to a significant degree so far, although there are ongoing trials, as I will mention. And then very importantly, to prove that as you lower Lp(a) using appropriate statistical data, that it will improve outcome, decrease death, and decrease cardiovascular complication and MACE, important question. So as a reminder, whether you look at the American US or you look at the European, we all know that we are targeting LDL as our primary focus, while we're not forgetting about non-HDL and others. So there is no change whatsoever. On the contrary, if the Lp(a) is found to be elevated, and although we don't have a targeted therapy to address Lp(a) specifically, we still will be more aggressive, more strict, more reinforcing, more and more. Everything, even lifestyle, even diet, medication, whether it's a statin, whether it's ezetimibe, whether it's PCSK9 inhibitor or inclisiran or other interventions, whichever are the ones that we're looking at. And to the right side, you could see that now with the European one, we're talking about the very high risk is aiming with LDL at 1.4 millimole per liter or 55 milligram per deciliter, with really an update of a very, very high aiming at 1.0 and a 40 milligram per deciliter. This is still true, ladies and gentlemen, as you probably know. The Lp(a) may not be affected or may be slightly elevated, more elevated when you give statin, and this should not alarm us. We still need to use the statin as main therapy, at least for now. Potential therapies, I'll go from the left to the right. I will address them quickly here and then show you a few data so I can finish on time and keep your attention and hopefully have a great session for question and answers. The monoclonal antibody, I'm sure you know, the monoclonal antibody is not only in cardiology or lipid, but in many things are very important and mainstay. While both of them, evolocumab and erucumab, do lower the Lp(a), it's not a targeted therapy. It's not FDA approved specifically to lower Lp(a), and it's a modest decrease. And other interventions I would discuss. And then there are interventions that are still experimental, not yet approved, but inclisiran does lower Lp(a), again, does not have an FDA approval specifically, at least yet, to address Lp(a). And then while niacin may lower it, it's not really indicated. And the only one indicated is lipid apheresis, just to kind of sum up for you before I move on. So As you know, PCSK9 inhibitors have been around now. We use them. These are the injectable drugs. I use them really routinely when they are indicated. In our region, we have a very good success rate with insurance companies when we really have appropriate documentation on our electronic medical record. And while they lower the LDL by increasing the LDL receptors, they do affect, as you probably know, LP little a, but in a modest way, and they are not indicated specifically for LP little a. Inclisiran works differently than a monoclonal antibody by addressing the mRNA, and by reducing those, we decrease PCSK9, which would lead indirectly to a decrease in the LDL. And then, very importantly, other interventions do the same. The message here is, while these things may affect the LP little a, as I'm trying to show here in this slide, but the lowering is modest and not very consistent. It's important. We don't know what it means yet as far as targeting LP little a and how much of the benefit is related to this, the outcome. But definitely looking at this meta-analysis, there is a lowering that could be up to 25% compared to the ones that did not have the antibody, as you can see in this case. Fourier, I mentioned that before, there is a lowering of the LP little a, as you can see in these slides that I put here. And you could see that this could be seen within even a period of 12 weeks. And this is statistically significant, but again, it's not indicated so far, at least for lowering LPA, specifically lowering LPA. Odyssey, which is alirocumab, significantly reduced LP little a level, and when we say significantly, is still a modest decrease. And again, there is no indication from the FDA that this is LP little a lowering, but again, when used, it has an impact, and I wanted to share it with you. Now, there are the RNA ones, targeting technology, the one that really look at affecting the RNA. So there is no protein, which leads to the formation of the LP little a. There are several, actually, I said 2 major methods, but there are several additional methods to really have less protein and less LP little a. And there are ongoing trials as we speak, recruiting quite a few patients to address some of these interventions. With inclisiran, which is a small interfering RNA, siRNA, was shown to inhibit hepatic synthesis of PCSK9 protein. And again, you could see that in Orion 9, 10, and 11, there was a decrease in LP little a after a while. So 510 days, which is not a small amount of time. It seems to be consistent, and it seems to be beneficial. However, these are numbers decrease that are modest. This has not gotten the approval of the FDA as the inclisiran being a specific LP little a lowering agent. This is probably one of the more interesting one, and I try not to be biased, but when you look at the data, this is right now a specific agent. It's called pelacarsen, and it's an antisense oligonucleotide, which you will hear a lot about, the ASO, which is against APO little a. And you could see, as the slide shows you, very interesting data, initial data at least, where this potent LP little a lowering agent can lower almost by 80%. And this will cause a reduction of the oxidized phospholipids, the one that causes the inflammation, reduce monocyte inflammatory activation, and very interestingly, lowering of the LP little a to really very low values. And again, ongoing trials are there, and please remember ASO, antisense oligonucleotides. Another one is pelacarsen. Again, as you know, I'm showing you here another study, 286 patients with established cardiovascular disease and LP little a. As you can imagine, I will not do these studies initially till I have patients with established vascular disease, like we've done with statins, and then for primary prevention, which will need obviously significantly more patient and time. I think within 3, 4, 5 years, we're going to have data not only on output, the specific lowering of LP little a, but outcome data on cardiovascular and all-cause mortality improvement and benefit. So dose dependent in Lp(a) is clear here. You could see the pooled placebo, 20, 40, etc., and 60, and you could see the numbers going down. And patients, again, starting with the intervention, and you could clearly see the benefit. So it is clear that we have something coming up and several ways to attack and lower the Lp(a), hoping to have the proof that the hypothesis that lowering Lp(a) will have additional benefit when it comes to cardiovascular outcome. Another ASO here is again looking at reducing the Lp(a). It's called mipomersen, and it's 382 patients on maximally tolerated lipid-lowering agent. And you can see this intervention did reduce Lp(a), and there was an interesting trend that was seen early on in the slide, as you can see here. The concerns is mipomersen is something that many of us have never used. It is indicated, at least in the United States, for homozygous familial hypercholesterolemia. And it would really not be a typical intervention to give an Lp(a) patient, because it does have quite a few side effects, including hepatotoxicity, flu-like illness, unless you do an appropriate risk-benefit and have outcome data, and hopefully be guided by the guidelines in how to proceed. Now, the final thing before I talk about niacin and few other things is the lipoprotein apheresis, or I call it LA, significantly lowers Lp(a), and we have outcome data. Countries that use it more than others are Germany, as you may know. Germany utilizes LA therapy for patients with an Lp(a) greater than 60 milligram per deciliter, and they have normal LDL if they already have cardiovascular disease. You will always notice that the patient needs to have cardiovascular disease. And again, it has to do with the charge, negative, positive, and there are ligands and dextrose ligands, we call them. And it really sucks. It's, you have it in one arm, and then the other arm. It has to be done every 2 weeks or every, 1 month. It's almost like a lipid dialysis. And it does lower Lp(a) remarkably, as I will show you. And this is one of the studies looking at this, and you could see how it can remarkably lower the Lp(a). There are also outcome data on this, and there are different ways how you could do this. There's absorption, filtration, precipitation, plasma exchange, which is rarely used. And you could see on the right-hand side the reduction, which I've summarized for you, which is the LDL lowering, but also an Lp(a) up to 74%, 70%, 71%, 88%, and 59%, 60, and 68% in the Lp(a). So clearly, it's a very efficient way to lower Lp(a). Looking at the FDA, our Food and Drug Administration in the United States. So those are the groups, briefly for the interest of time, that they talk about, which is functional hypercholesterolemia homozygous with an LDL greater than 500. This is an obvious one. These patients are very, very concerning. Functional hypercholesterolemia heterozygous with an LDL greater than 300 milligram per deciliter. Group C, functional hypercholesterolemia heterozygous with an LDL greater than 100, and either documented coronary artery disease or documented peripheral vascular disease or arterial disease. And then importantly, where it's related to our topic today, is group D, Lp(a) greater than 60 milligram per deciliter, and an LDL greater than 100 milligram per deciliter with either documented coronary artery disease or documented peripheral arterial disease. So this is from the FDA and our understanding. And again, this slide, again from Dr. C. Mikas, who has spent literally most of his professional life and research on this very important topic. And we all should thank him and appreciate the great work he's done. And you could see here some of the hypothetical changes that you could expect on an Lp(a) of 150 milligram per deciliter, which is quite elevated. You could see that the ASO, the antisense oligonucleotides, will be very focused, specific to the Lp(a), with almost a 99% change. The effect of apheresis, initially it's around 60, 65%, but with time, it levels at around 30-35%. The effect of niacin, which I will briefly mention, PCSK9 and other interventions, and 30%, but again, niacin was not indicated, is not indicated, although some colleagues use it for Lp(a). And then the effect of statin, in spite of the increase of up to 20% sometime in Lp(a), we do know that there's a benefit. And, this is not something that should stop us. On the contrary, we should be more aggressive in doing this. Are there algorithms? Really, I struggle to find an algorithm is very clear. This could be one, but, it's not final. It's patient with elevated Lp(a). Do they have existing vascular disease risk factor that should be treated? Does the patient have progressive CAD, coronary artery disease? Should we reduce the Lp(a)? Should we go with some of the current intervention that modestly affect this? Incidentally, aspirin does lower your Lp(a), especially in stroke patient. And anyway, we use it, but the lowering is very modest. Or should we go with antisense therapy? Obviously, it's a big topic. Now, the comment is, does diet lower Lp(a)? Diet is not known to lower Lp(a), but it has numerous other benefits, so we should continue to do it. And there's a huge debate regarding carbohydrates or unsaturated fats, whether replacing it with saturated fat affects Lp(a) or not. I recommend, and many of my colleagues and experts in the field, to continue to have appropriate balanced diet and to wait for more data to come up on Lp(a). Slide that I removed were on, as I mentioned at the beginning, flaxseed. There are meta-analyses that they may be beneficial, pill or in diet. Something on ginkgo biloba, but very limited data, and also on turmeric. Again, you may believe in this anyway. Turmeric and flaxseed are very healthy. Why not? Go ahead, and they have additional benefit, but no solid outcome data. Exercise, unfortunately, and I'm an exerciser. I bike and I run and I walk routinely with my wife and the family, but unfortunately, no current data showing a change in Lp(a) in the beneficial direction. Summary. Before I go into the detailed summary, which I rarely have a summary with 3 slides, but in this case I do. First, I want to thank you for the attention and thank the organizing team and the technical team for all their efforts and their support from the United States of America. Second thing I want to bring up is the topic is complex, but at the same time is very beneficial. Because I think there is hope now that we can even do more to prevent, stop this firefighting thing of it's already, the building is burned, but we saved people, and say we prevented the fire in the first place. And this could be another cornerstone, another horizon, another addition, another league in our journey in preventing cardiovascular disease and other similar illnesses. And with that in mind, I want to summarize to you what I wanted to say, and some slides I removed, so you may not have had all the support for the summary, but hopefully you'll accept these statements. Lp(a) is atherogenic lipoprotein with strong genetic regulation. I told you it's co-dominant, and it's really something worth checking. Lp(a) levels are primarily regulated by the apolityl-A gene size polymorphism. And I spoke about the copy of Kringel's repeats that will be impacted by ethnicity, somewhat by the environment, and also medical condition. I spoke about acute phase reactant, spoke about kidney disease, diabetes, etc. The concentration show several hundred-fold inter-individual variation, ranging from patients have less than 0.1 milligram per deciliter to the unbelievable 300 milligram per deciliter. Significant variation. Epidemiological data consistently indicate a direct and dose-dependent risk association. It's still a risk. I have patients with an elevated Lp(a) who are fine, and we did the full workup and they are fine, but still, statistically speaking, Lp(a) with atherosclerotic cardiovascular disease, and interestingly enough, calcific aortic valvular disease. Lp(a) plasma concentrations above 300 milligram per deciliter, and even more above 50 milligram per deciliter. And I told you about the nanomole unit, are associated with increased risk of cardiovascular disease, including myocardial infarction, stroke, aortic valve stenosis, heart failure, peripheral arterial disease, and all-cause mortalities, ladies and gentlemen. Despite its demonstrated contribution to atherosclerotic cardiovascular disease, there is lack of a standardization in the assay, although some institutions do have it. The guidelines are not consistent, although I think the European Society of Cardiology recommending at least once in a lifetime, I fully support, and targeted therapy, not to lower it by the way, but rather directly lower it, are on the way, but we don't have yet the appropriate outcome data or the approval for FDA to tell us that this is really indicated. And it's interesting that patients and doctors do not have it checked at least once in a lifetime. Something to keep in mind that the majority of LDL levels in clinical medicine are estimated, and this has an interest related to Lp(a) because part of it is going to be Lp(a), obviously. Lp(a) cholesterol correction of measured and calculated LDL should be applied, and keep in mind that the component here is clearly the Lp(a) concentration, and keep in mind that this may be an additional indication to measure or check the Lp(a). Different guidelines, European Society, American Heart Association, among others, recommend Lp(a) testing at least once in a lifetime, if not more, to refine the atherosclerotic cardiovascular disease risk. And finally, a summary of the summary is no approved pharmacological therapies that specifically target Lp(a) concentrations are there, and I understand that. However, some therapies can target it primarily. I mean, if I mentioned, for example, aspirin. I've removed the slide of aspirin for the interest of time. In giving aspirin, if I have a patient with elevated Lp(a), I look at the data, look at the guidelines. And vascular conditions, etc., etc. PCSK9 inhibitors that lower LDL cholesterol that by a significant degree, at least 60%, do lower Lp(a), not consistently, but to a certain degree, to up to 30%. And however, this is not a targeted therapy, and we don't have proof that the benefit is directly related to the Lp(a). It's rather likely to be related to the LDL plus or minus Lp(a). New therapies targeting RNA, such as the antisense oligonucleotides, which we call ASO, or small interfering RNA, against ApoA, the main protein of Lp(a) particle, are under examination, and they can lower concentrations, at least the targeted therapies, up to 90%. So proof of concept from the initial data is that they lower, that's the output. We need outcome data, obviously, to show that this affected the outcome of the patient. Aspirin, again, I told you, I've removed the slide, lowers the increased Lp(a), especially in patients with ischemic stroke. And anyway, we give aspirin, so I think it's reasonable to go ahead and do it. Niacin, some people use it, but again, there are no outcome data on niacin and cardiovascular disease that recommends using it, and this is going to be individualized care. It does have side effects, liver and more diabetes, etc. So we have to weigh the risk and the benefit. Lipoprotein apheresis clearly lower both Lp(a) and LDL. It's the first FDA indicated treatment of elevated Lp(a) in the right groups that I showed you. I showed you the 4 groups. The 4th one was on Lp(a), but again, it's not very practical, it's expensive, and it has its own concerns, and many patients will not be interested in pursuing it. And there's also availability issues. Lp(a) levels are largely determined by genetic factors and may have minimal influence, as I told you, related to diet. Again, not shown today, but to keep something a little bit interesting, because patients will ask you about this. They ask me, they ask you, they ask everyone. And, flaxseed, interesting meta-analysis, curcum, again, interesting, and ginkgo biloba. And maybe they can reduce, but the clinical evidence are limited. Keeping in mind all of these, ladies and gentlemen, LP little a is something worth knowing about, something worth checking at least once in a lifetime, something worth following carefully the current and upcoming trials in specifically lowering it. We are awaiting outcome data. Till then, my patient, your patient, myself, yourself, if we have an elevated LP little a, we should use it as an indicator for a better lifestyle, a more lowering of the LDL cholesterol and modification of other cardiovascular risk factors, and always hopeful that we are on the track of preventing.
Professor Ellahham, for the wonderful presentation. We will now move on to the question answer sessions. We have received quite a few questions from the audience, and in the interest of time, we will go through a couple of questions. So the first question that we have received is, do you recommend repeated measurements of LP little a for a high-risk patient, and which frequency should be considered? Professor Ellahham.
That's great. So thank you for the question. And by the way, this is being recorded. So if your colleagues were not able to attend due to time limitations, please share them. So number one, the recommendations from European Society of Cardiology and lipid expert is to have at least once in a lifetime LP little a taken. Message number one. Message number two, when someone has an acute myocardial function, as I said, or an acute illness, this number can go up more than what it really usually is. So we recommend to wait 48 hours, or if someone has a major inflammation or infection, then they have to take it later on. However, what we know is that typically LP little a stays with us at the same level, except the examples that I've given you: menopause, pregnancy, patients who have acute illness, acute phase reactants, and few other things. This is the current knowledge of what we know about LP little a. This may change in the future. A simple message for all of us: have it tested at least once in a lifetime.
Okay, thank you for the great answer. So for the second question, I will read out the lipid profile of an individual, and based on that, the question asked is whether the condition will be considered as hyperlipidemic and whether there is any need of medication. So the values are LDL 160, HDL 55, triglyceride 100, and total cholesterol 260. Professor Ellahham.
So as you know, we don't treat dyslipidemia, we treat patients. So number one, and most importantly, is while the numbers are obviously quite elevated and they will make me treat the patient, please let's remember three things. Number one, and most importantly, we look at the risk profile of the patient. Whether we use the European score risk, or we use the Framingham in the United States, or the one in Germany. India has a couple of them. We also have some in Japan and Australia. Number one, remember, we treat the patient, not the lipid profile. So we need to know more about the patient. Second thing is, we need to know, is it what we call appropriately or inappropriately primary risk reduction, or secondary? Means, does the patient have already vascular disease? Did they have a stroke? Did they have a heart attack? Do they have peripheral arterial disease? And number three, and most importantly, we want to make sure we have a good lab that is, CAP accredited or WHO accredited, etc. So please remember those three. With that in mind, clearly the LDL here is remarkably elevated. I want to remind you to look also at the non-HDL of the patient. Even if the HDL is elevated, I happen to have worked briefly with my colleague at NIH, who was the HDL world expert. HDL is very heterogeneous. LDL is less heterogeneous. An elevated LDL in the right setup, in the right risk group, based on the slide that I've shown you in the European Society of Cardiology, knowing what the patient has can lead to a treatment with either a statin, or we combine it with ezetimibe, which obviously would be the single pill therapy that we recommend to improve compliance. And when needed, those patients could be considered for either a PCSK9 inhibitor or even inclisiran. Please remember, if there is any message from today, I will make 3 to end. Number one, and most importantly, we treat patients, not lipid profile. We stick to the guidelines, and we consider at least once in a lifetime to have an Lp(a). And for anyone who says we can't do much about it, we look at family history, we can't do much about it. We look at age, we can't do much about it. We look at gender, male, we can't do much about it, but we still become more strict about treating patients. Use the Lp(a), use the score risk, use the Framingham to improve patient compliance and more commitment to a better lifestyle. Thank you so much.
So the next question that we have is how to know about and observe one's body that LDL is high without the lipid profile test.
Do you know, you mean clinically? Can you please repeat the question?
Sure. So it is how to know about and observe one's body that LDL is high without the lipid profile test.
So that's an interesting question. My colleague is asking about familial hyperlipidemia, where we obviously have depositions of fat in the skin, especially in pressure areas. If we have, my colleague is asking whether the patient has a familial history of either familial homozygous hyperlipidemia, which is approximately 1 in 300,000, or heterozygous, which is around 1 in 250. Or whether we're looking at groups that were known to have the LDL. But obviously the way to do it is to have an appropriate lipid profile done in an appropriate lab. This is typically cost effective. Now we even have point of care testing where this can be tested even in a small group, even literally can be done at home. So I highly recommend that we go to the standardized way of checking lipid profile and do it at least, as recommended by the guidelines.
Thank you, Professor Ellahham. So as we are on the hour, we are going to wrap up today's session. And on behalf of the team at the Wiley Knowledge Hub, I'd like to thank Dr. Ellahham for his very insightful presentation and for answering audience questions. I would also like to thank the audience for their participation. We look forward to meeting you all again when we bring our next webinar on May 19th on the prevalence of statin intolerance, where we will have 2 key opinion leaders, Professor Christopher Cannon and Professor Mathieu Banac, discussing this topic. Once again, thank you all for your participation. The recording of today's webcast will be available shortly. Please visit the Wiley AACVD and Lipidology Knowledge Hub to view these and other relevant resources. Thank you.
Thank you.